So I'm going to talk about role of elbow arthroplasty in trauma, keeping in view the theme of the conference of adapt and evolve. So distal humerus fractures are common, especially they form about 30% of elbow fractures, and we've heard a great talk with lovely examples of how to fix them. And there's a bimodal age distribution. The younger patients, I think we all will fix them, but it's the elderly patients with a relatively poor bone quality where we do try and fix them, but sometimes they do fail. And when they do fail, we end up doing primary arthroplasty. To the extent there have been a lot of papers, some systematic reviews suggesting that we must advocate primary elbow arthroplasty in the elderly patients with these comminuted distal humerus fractures. We have been doing the linked total elbow arthroplasty for these cases for a long time. However, it's not without its problems. Significantly limited weight restrictions, the active patients don't like it. There's high complication and reoperation risks, and a lot of work done at the Mayo Clinic at Rochester have said that 30% risks of reoperation, high aseptic loosening rates, periprosthetic fractures, and late complications of the polyethylene bush wear, and the wear leading to osteolysis of these prostheses, of the bones, is a big issue. So there has been a renewed interest in the elbow hemiarthroplasty. Obviously, it has the advantage that there is no linkage, there is no polyethylene, which will lead to the wear debris, and less likely to have component loosening, as there is no linkage and no other component to adhere to. Is it more suitable in the younger patient? Well, some people have suggested that, but I'm not sure about that. Elbow hemiarthroplasty is not something new. It's been going on for a long time. As far back in 1947, Mellon and Phelan, they started using a customized acrylic implant, but they used it in very young active soldiers for very complex intra-articular fractures. In 1965, Barr and Eaton made a customized prosthesis for a patient with a distal humerus fracture. One of the first series you can find is from Street and Stevens. 10 patients, a mixture of patients, some with ankylosis, some with rheumatoid arthritis. None of them were acute trauma, but they did have varied results. So initial papers have shown not so good results for these. One paper which showed some encouraging results was from Adelson and Hamer in 2006, but they had about 4 patients in that series, and 3 did well, but 1 did very badly, so 25% failure rate. And the problem is the initial hemiarthroplasties were done by using components which were not really catered for a elbow hemiarthroplasty, though they do say that we can use them, but they're mainly unlinked total elbow replacements, and we're using the hemiarthroplasty, the humeral component for a hemiarthroplasty. Newer papers have started showing very encouraging results with hemiarthroplasty. There has been a systematic review in 2014. They looked into 17 papers, 13 of which were for acute trauma, a total of 133 patients. And the conclusion is that distal humeral hemiarthroplasty is a reasonable treatment for unreconstructible intra-articular fractures. They've also extended it to rheumatoid arthritis and tumors, and even malunions and osteomyelitis. This is an individual case series of 42 patients from Nesterson, which was published in British Journal in 2015, and they had very encouraging midterm results with elbow hemiarthroplasty for acute trauma cases. Denise Eggendal's unit had shown good results in 6 patients. They used this for acute trauma. So why have suddenly papers started coming out with encouraging results? And this is because of the concept of adapt and evolve. And we have evolved into using better prosthesis, customized prosthesis. And this is one of them that is available in the market called the Latitude Anatomic. Surprisingly, it still doesn't have FDA approval for it, but this is what it looks like, and it has various combinations of stem and spools. Um, and some of the extent of this good results that we are having with elbow hemiarthroplasties is because of our improved understanding of the problem. The implants are getting more specific, our approaches are getting better, and Mr. Fudness, who is one of our speakers, has done a lot of work on this, especially using the triceps on approach for fixation, for doing a hemiarthroplasty. We understand the role of collateral and preserving them for these cases. There have been reported complications, the usual of infection, nerve injuries, mostly neuropraxia. Contractures is common with most elbow surgeries, as is HO. There's not been much published as such, or we haven't seen a lot of problems with ulnar and radial wear, but it is a possibility, and possibly with more and more us doing cases, we might see them in the near future. But HO with elbow surgery is common and can be a problem, especially like in this case where it is like a grade 3 HO where you're getting a bit of ankylosis, and we had to go and take the ankylosis down to get the patient moving again. And instability, if you don't understand the need of preserving collaterals for this surgery, then you are doomed to failure, as in this case where the hemiarthroplasty looks decent and well preserved, but I'm not sure how they will achieve stability in the long term. In the short term, they may just use some sutures to tie it through the prosthesis, but long term, it may be doomed to failure. So what's my experience? Well, if I have a distal humerus fracture in the elderly, my priority is still to fix them where possible. And this was my first ever case about 7 years ago. A lady who worked in a corner shop and used to do a lot of stacking of shelves and had a really comminuted distal humerus fracture, for which I did a hemiarthroplasty, and she did very well and is still doing her job all these years later. So how do I do it? Like I said, priority is still to fix. I do tend to get a CT scan for all the cases before I proceed. It's a planned urgent case. I'm always prepared to convert it into a total elbow replacement, though I have never needed it to, and I don't think you will need to in majority of the cases. However, I have converted the other way around, where I thought I might do a hemiarthroplasty based on my CT scan evaluation, and when I've gone in, I felt it's fixable, so I've gone ahead and fixed the fracture. So let's take this case, a 57-year-old male who had this kind of a fracture, and he was pretty active, but more of a sedentary job, but loved to go on long walks. And this is what he did when he fell while walking down a hill. We did a CT scan, and when I looked at the CT scan images, I felt that the whole distal humerus had blown out. And I felt it was possibly not easy to save it and fix it. So this is the position I do it in, lateral position with a tourniquet, posterior approach. And I still tend to do a triceps tongue down flap, which I've been doing for over 20 years now for distal elbow approaches. You open the joint through the tongue down flap. I always use a yellow vascular loop to identify my ulnar nerve to remind me where it is, but never tag it down with any other instruments, as Professor Bijender suggested. This is what it looked like after we cleared it. I'm not sure if it is very clear, but the condyles are sitting here. There is one condyle on this side and the other is here with its attachment of the collateral ligament. This is what I ended up after taking out all the bony fragments. It looks a bit worse than what it is, possibly because I had to nibble a few out. But then you use the sequential reamers to ream it. The kit is quite good. You broach the canal to the size you want it. These are very instruments which are similar if you're going to do a total elbow replacement, but it's the spools at the end which you use measure the anatomical spools that you use, which are slightly different to the total elbow replacement from the same company. You can trial it and you size it using the ulna cavity as the sizer for your implant. The trial sits nicely, the radial head is not excised, and there is an extension on the radial side to articulate with the radial head. It's an excellent paper from Fudness and his co-authors telling us how to repair the condyles back so that you can still use it in these comminuted fractures. The prosthesis allows us to put some sutures through the prosthesis itself, but it's important to attach the bone to the shaft as well, using sutures as shown here. And this is what it is. You can see the sutures passing through the condyle and going into the prosthesis. And once the prosthesis is put in place, these sutures can be tightened and the condyles can be stitched through the prosthesis as well as through drill holes within the bone, and you can tie them down together. And this is what the X-ray looks like immediately. I'm slightly overprotective when the condyles are fractured for the first couple of weeks and do put them in a plaster, a back slab. If the condyles are intact, I just put them in a woolen crepe and get them moving gently within the woolen crepe. The condyles do heal, and this is an X-ray taken 6 months later for the same patient, and you can see the condyles have healed well, giving good function to the patient. So this is one of the earlier cases I did. Similarly, very comminuted distal humerus fracture, but here I had used anchors to suture the condyles back into place. Possibly I hadn't read Joydeep's paper till then, but once I read it, I've started using just the sutures as his paper has advised. Some of these patients which look like innocuous fractures can be more difficult to fix because of the crushing of the articular surface. And but another example showing that condyles heal well. I have used this in this case with the comminuted distal humerus fracture, which also had an olecranon fracture. So I'm quite happy to use them by fixing the olecranon fracture and doing a hemiarthroplasty. And the X-ray with the implant in is at least 6 months after surgery, and patient is doing quite well. So it's a good option to have in your bag for these comminuted distal humerus fractures, especially in the elderly. And we have all adapted over the years. John Charnley adapted the Austin Moore hemiarthroplasty that we were using for hip OA as well, and came to do a total hip replacement. We know Charles Neer started looking at a shoulder hemiarthroplasty in the 50s and then progressed on to a total shoulder replacement when he first published it in 1974. We don't always have to go from hemi to totals, as can be seen for elbow trauma, where we have used to use total elbow replacements and we have adapted and evolved to go towards the hemiarthroplasty. Thank you very much.